pension, these are also eating either into the health budget or into the budgets of families to make them even more poorer. The theme for this year comes at a time when even funding has dwindled. We have seen some donors stopping or cutting their aid, and others shifting their priorities. And we also have a domestic debt which Malawi must service. So it is a good time that we must be discussing these issues and even look into how we can raise resources domestically so that healthcare services, and especially primary health care, is financed and does not suffer. We believe as a UHC coalition that much as we are servicing the debt, but the essential services like the health sector must not be much affected, because anything that happens, either someone must be forced to pay with regard to the theme or the principle for universal health coverage, or someone who cannot afford stays at home and may be dying silently. Honorable guest of honor, we also note that at the moment, the United States government has an intention to resume targeted global health funding through a new government-to-government model. While as the UHC coalition, we welcome renewed engagement, we also urge that Malawi must look into her full health priorities. Especially, we should not forget maternal and neonatal health, mental health, NCDs, and family planning. That these must be fully reflected and considered in the negotiations, especially for the agreement. And in that case, our national needs will not only be shadowed by disease-specific priorities. We also recommend that key stakeholders should be engaged, like civil society organizations, parliament, and the like, in the discussions, especially whether it is the Minister of Foreign Affairs or Minister of Finance or Minister of Health, whoever is at the helm. So we'll support with the ideas and the solutions wherever input is required. As the coalition, we call for bold action as we go into realization of universal health coverage, such as protecting health, education, and agriculture budgets from any austerity measures that are there. When it comes to financing primary health care, prevention, and early detection, especially for NCDs, must be well financed, and that can be cheaper than treating NCDs. There should be expansion of fiscal space through progressive taxes, including on sugar beverages. They need to have some taxes which should make them not easily affordable. And we have seen them on the increase in the nation, which might also be reflecting why we have more NCDs. And above all, ensuring that an equitable health insurance system is developed to shield citizens from any costs that come at the point of access. So let our deliberations today move us closer to Malawi, where health services are affordable by everyone, accessible, and equitable for all, where no Malawian is denied care because of course its distance or the absence of some medicines. Honorable guest of honor, as I conclude, allow me to recall that during the 2022 UHC Day commemoration, for which we are lucky you were also there in Nchinji, we appealed to the Minister of Health to restore Kochilila Health Center to its former status as a community hospital. That time, the ministry gave some directions to Nchinji District Council to do some quantifications and the like. And we also remember that in the 2023 UHC Day, we met at Chibonde, where we had an uncompleted health facility which had stored for more than 10 years. And we requested that it should be completed. For Chiponde, we are happy and we should acknowledge that it was indeed within the shortest period completed, and it is in good shape. Coming back to Kochilila, the commitment or our request which we made has not been fulfilled yet. And we respectively renew that appeal today in the spirit of our collective responsibility that Kochilila should still be considered to be upgraded to a community hospital. I thank you very much, guest of honor, honorable guests, and ladies and gentlemen, for your attention. Once again, you are welcome to this day on behalf of the UHC Coalition. Thank you.
Thank you so much, our esteemed chair for the Universal Health Coverage Coalition. He has made it very clear to say that as the whole world is commemorating this particular day, it's very important to look at the financial cost aspects to make sure that everyone is not left behind, that everyone is able to access these very, very important health services without suffering the financial costs. Without wasting much time, at this point in time, Honorable Anthony Masamba, who is with us here, we are honored that we have the Parliamentary Committee on Health who are with us here. Now it is your time, sir, to come and give us your remarks.
All right. Thank you very much, moderator. Secretary for Health Administration, Mr. Chisamire, Chairperson of the UHC Coalition, Mr. George Jobe, partners, stakeholders here present, ladies and gentlemen, good morning. So first of all, I would like to say that I'm back home because I'm one of the founding members of the UHC. When I was with Oxfam Malawi, I was the secretary for this coalition, and being here today just tells me or rekindles the memories that I had when I was with UHC. I'm in another space now, but that doesn't take my membership away from this coalition. So I'm one of you colleagues. I thank the UHC Coalition for creating the environment platform, the chairperson that has clearly highlighted that the financial reality of the health care in Malawi allow me to build on that from Parliament perspective. Ladies and gentlemen, history shows that the health committee receives stories of families who cannot afford medicines, diagnostics, or transport to health facilities. Out-of-pocket spending is too high. For many Malawians, facing risk is a financial disaster. We also recognize that inefficiencies, which include drug leakages, weak procurement systems, and wastage, continue to erode public confidence and drain resources that should protect citizens. Colleagues, allow me therefore to highlight that the Health Committee shall strengthen engagement efforts between the Ministry of Finance and Ministry of Health to ensure that health budgets are adequate, realistic, and focused on essential priorities. The committee shall always seek to support calls for increased allocations for primary health care, essential medicines, health allocations to primary health care, essential medicines, health workers, and the growing burden of non-communicable diseases, especially for the marginalized communities. However, adequate resources are only part of the equation, as accountability must be strengthened. It is for this reason, therefore, that the Health Committee will seek to intensify the oversight functions to ensure that every kwacha allocated to the health sector delivers results and reaches those who need it most. But ladies and gentlemen, I think this is the right time that we need to start discussing the locally generated solutions towards health sector, because we are experiencing the donor fatigue. Most donors are scaling down their funding towards not only health sector but other sectors as well. So for us to realize the UHC, whose pillars are accessibility, affordability, and even availability, we need to start thinking about how can we, as Malawians, achieve the UHC, because the donors are walking away. So in the absence of donors, what can we do as a country? Now we are talking about the 5 billion allocation to district councils. How much should that 5 billion be allocated to health sector? If we start thinking about that, then we are on the right path to achieving the UHC, because in the absence of the strong mechanisms and strong advocacy towards partners and government, then the dream of achieving UHC is far-fetched. So as a coalition and as partners, let's look at what can we do, what other solutions generated locally to help finance health sector, which will help in the long run achieve the dream of having everyone accessing healthcare services without exposing them to financial hardships. The Health Committee looks forward to working closely with the Ministry of Health and Sanitation, Ministry of Finance, civil society, and development partners to tackle the bottlenecks limiting accountability and accessibility of health services. But we could be here gathered discussing the UHC while knowing that the donors, traditional donors, are walking away. I think this platform today should focus much on how much as stakeholders, how much as civil society organizations, including the government. WHO is here. Let's focus much on discussing the solutions, locally generated solutions, because if we focus much on donors, then we are losing the plot. Because time is now. Time is telling us that donors are shifting their focus. The Trump effect, for example, has affected not only health sector but other sectors as well. So if you are gathered in this platform, a platform like this one, let's bang heads and let's come with proposed solutions collaboration. Let's strengthen the mechanisms, the anti-corruption bureau. How much? Let's look at the supply chain, the phosphate drugs, several other issues that we can discuss to ensure that this UHC dream is actualized. Together we can make universal health coverage a lived reality only and only if we consider focusing much on locally generated solutions. With these few remarks, ladies and gentlemen and guests of honor, allow me to wish you all the best and thank you very much.
Thank you so much. The chairperson for the Parliamentary Committee on Health, Honorable Anthony Masamba, our esteemed guest of honor from the Ministry of Health, the Principal Secretary for Administration, Mr. Beston Chisamire, and everyone here. Today is a very, very important day. We're talking about the affordability of healthcare services. Let's be reminded that this particular event is being live streamed. It's live on Luntha TV. At some point, our colleagues from Luntha are going to help us to share the link so that all of us can follow. I think it's also on Facebook, so if you're already linked to Luntha Television, if you just check the page on Facebook, you should be able to join the live streaming. So we're here, we're being live streamed, and the whole country is actually watching us online. So it's very, very, very important to remember that. So at this juncture, we also have our ministers, the World Health Organization representative, Dr. Nelly Yatich. I'm hoping I've pronounced correctly, Madam. Yes. So kindly come in front. It's your time to give us reflections. We know that WHO is under attack by Donald Trump. It's something we should be hiding. So we also want to hear from them to say, as the UN, what are they looking at in terms of this particular important day. Over to you, Madam.
Thank you very much. Muribwanji. I hope I'm pronouncing it correctly. Our guest of honor, Mr. Benson Chisamile, the Principal Secretary of Administration, Honorable Anthony Masamba, Chairperson Parliamentary Committee on Health, the Chairperson UHC Coalition, Mr. George Jobe, representative from the Patient Association, representatives from the Ministry of Health and other line ministries, bilateral and multilateral agencies, implementing partners, Chair of the National Organizing Committee, civil society organizations, communities, families, individuals, members of the press, ladies and gentlemen, good morning once again. So on behalf of WHO and the Health Development Group, so I'm here speaking on behalf of both WHO and the Health Development Group in Malawi. We appreciate the Ministry of Health and Sanitation, the chairperson of the UHC Coalition and partners for annually organizing the celebration of the Universal Health Coverage Day, which is commemorated on 12th December. In Malawi, the civil society as part of the UHC Coalition and the Ministry of Health and Sanitation has coordinated all stakeholders towards this commemoration of UHC Day 2025 under the theme of an affordable health costs, we are sick of it. Distinguished guests, as part of the journey towards universal health coverage, which is UHC, WHO calls for urgent action towards implementation of financial protection measures and eliminate out-of-pocket costs, health costs for vulnerable population and those most in need across the life course approach. That is from children to adolescents, including both boys and girls, young women, pregnant women, and older persons, persons with disability, and also persons from low-income communities, as well as persons with chronic conditions. Financial protection is at the core of universal health coverage and one of the final coverage goals. Ensuring financial risk protection is part of UHC coverage. It's recognized as one of the targets also in the Sustainable Development Goals. The WHO advocates for health financing systems that prevent families from facing financial ruin by ensuring that they can afford care through broad risk sharing and prepayment mechanisms, rather than relying on individual, often overwhelming out-of-pocket payments. Malawi's health system continues to rely significantly on external assistance, as the Honorable MP has said, and this is dwindling very fast. So currently, Malawi's contribution from external financing is 47.3% of the total health expenditure. The government of Malawi is, however, to be commended for its sustained efforts to reduce out-of-pocket health expenditure for individuals and families, even as pressure on household spending have increased from 11.9 to 13.2%. But there is effort towards reducing this, and this is commendable. This commitment, alongside the government's clear willingness to chart a progressive pathway towards increased domestic financing for health, is critical to gradually reducing donor dependence and advancing the achievement of UHC objectives and goals. The renewed focus on PHC encompasses building resilient health systems, ensuring equitable access to quality health care, leaving no one behind, addressing social determinants of health, and the effects of climate change using a multi-sectoral approach. WHO lauds the government of Malawi for implementing strategies to address stockout of essential health medicines and supplies, and also for its commitment to build a stronger supply chain system, address long distance to health facilities with community-based service delivery outreach models, and also addressing the shortage of human resources as part of health system barriers to equitable access to care. Malawi has also strengthened its health security through improved preparedness, epidemic response, and climate adaptation, successfully controlling diseases like cholera, and now on the course to contain mpox through multi-sectoral response. So this is one area that Malawi is really strong in and is a model for other countries in the region, and we must applaud the Ministry of Health and Sanitation for this. Please, let's give them a clap. As part of collective action, the health development partners remain fully committed to walking the path with the government of Malawi to realize the aspiration of its health sector strategic plan 3 under the theme of reforming UHC. The health development partners commit to supporting the government to support Malawi's health system, the health system strategic plan 3 and the Lusaka agenda for PHC-oriented systems, advocate for predictable financing and pooled resources to reduce out-of-pocket costs, strengthen social protection and climate-resilient health systems, improve data and monitoring of health financing and equity, and support innovation for alternative health financing mechanisms and models. So on behalf of the health development partner groups, I wish all participants a productive and successful commemoration of the UHC Day. We look forward to continued collaboration, and as we proceed for the holiday season later on this month, I want to wish you all happy holidays. See you next year. Thank you very much.
Thank you so much, Dr. Nelly Yatich. She's the representative from the World Health Organization. She mentioned very critical issues. She's talking about the linkages between climate change and health. We know now that we're in the rainy season. That's why we see the increase in waterborne diseases, and some of these waterborne diseases are also increasing as our globe is heating up. So as the waters are heating up because of that heat, extreme heat, it's also bringing a lot of climate-sensitive diseases like diarrhea, cholera, and others. So it's very important that when we're looking at universal health coverage, it's also important to strengthen the primary healthcare system, the PHC, which you talked about being quite very critical. At this juncture, ladies and gentlemen, our esteemed guest of honor, Benson Chisamire, and also our honorable member of parliament for the Parliamentary Committee on Health, Honorable Anthony Masamba, and everyone. I would now humbly call upon our guest of honor, Mr. Benson Chisamire, who happens to be the Principal Secretary for Administration for the Ministry of Health and Sanitation. You can come in front, and over to you, sir. And let's give him a round of applause, please. Yeah.
Thank you very much, our Master of Ceremonies. I would like to recognize in a special way the chairperson of the Parliamentary Committee on Health, Honorable Anthony Masamba, MP, the chairperson of the Universal Health Coverage Coalition in Malawi, Mr. George Jobe, and your team, welcome. The representative of the World Health Organization, country representative, here present. The surname I will not manage, but Dr. Nelly. The representatives of the civil society in Malawi. I managed to speak to Mr. Maziko Matemo, but he's not around. But there are other representatives. The development partners here present. Directors or senior officials from the Ministry of Health, and all senior government officials here present, our media colleagues, distinguished ladies and gentlemen, good morning. Good morning. That's much better. First, I would like to extend my apologies for coming in late. I think Mr. Jobe mentioned, when I looked at the prepared speech, it was saying Sunbed Capital Hotel. So from office, I rushed to Sunbed, and in the Capital Hotel. And I looked around, I could not see anyone. I called Mr. Maziko Matemba, he's the one who told me that it's here. So when driving to come here, I find the places, the roads are closed. I was told to go behind. So that took much time. So once again, apologies. Colleagues, on behalf of the Honorable Minister of Health and Sanitation, Honorable Madaliso Baloi, MP, I stand here to grace this function. We gather here today not merely to commemorate the Universal Health Coverage Day, as we do each year, on the 12th of December, but to reaffirm our commitment to the global commitment principles that access to quality health care must never be determined by one's ability to pay. I think Mr. Jobe highlighted on those issues. The theme for this year is the unaffordable health costs. We are sick of it. This theme reflects the daily reality for millions of people globally, and also Malawi, that are forced to choose between seeking health care and also getting basic survival needs. For Malawians, unfortunately, we are also not spared. Over the past 3 years, the households out-of-pocket payments have averaged about 30.5% of the total household expenses, meaning that there isn't much that a household would even spare to get medical care. This situation is not aligned to the World Health Organization's health financing policy recommendations. I think the representative highlighted on that, which urges countries to move forward predominantly into prepared and pooled resources to ensure strong financial protection to the poor. We may also wish to note that there are a number of challenges in the healthcare system. Distinguished ladies and gentlemen, government remains fully aware of the complex challenges that continue to constrain our health system. Allow me to highlight some of the key issues. One is an evolving and rising burden of diseases, and this increases demand on already constrained resources. The MC did mention to that, especially now we are in the rainy season. There are a lot of waterborne diseases. Secondly, the recurring shortages of medicines and medical supplies, often forcing individuals to purchase medicines out of pocket or seek care elsewhere at their own cost. I think that has also been highlighted by the previous speakers. 3 is a declining and unpredictable donor support in terms of the resources that can go into the health care. Despite these challenges, distinguished ladies and gentlemen, the government has managed to do the following. One is increasing investment in integrated primary health care, and also continuing to mobilize resources for direct facility financing. 2, strengthen information management systems. This includes electronic medical records, medical equipment, and the management of the laboratory systems. 3 is exploring innovative health financing mechanisms such as the public-private partnerships and scaling up of option paying services. You might have experienced that in some of our facilities, including Kamuzu Central Hospital, Queens, and the district hospitals. There are some wards now where government is offering optional paying services. Distinguished ladies and gentlemen, to make meaningful progress towards the universal health coverage, the ministry recognizes the need for strengthened collaboration and partnerships. As such, the government will continue to work closely with members of parliament, especially the committee where Honorable Masamba chairs, to lobby for health financing legislation and oversight. Already in the current budget, during the mid-year review, there were issues also to assist the Ministry of Health or the government in terms of financing through the insurance. So what we are proposing is that we need to have so many avenues where government can generate resources to support the demand on the ground, and also noting that the donor support is now reducing. Secondly, we are saying we need to deepen collaboration with the civil society, development partners, and the private sector. So, Mr. Jobe, with the Universal Health Coverage Committee, indeed, we need to work hand in hand with you to look at these issues of making sure that health care is provided to the masses at affordable, equitable, accessible means. With that, before I conclude, distinguished ladies and gentlemen, can we clap hands for the initiatives that the Universal Health Coverage team and also our development partners, that includes WHO, are supporting the government? Can we clap hands for them? Distinguished ladies and gentlemen, in closing, allow me to sincerely thank the Universal Health Coalition in Malawi, who have organized this important event, and all those who have contributed to the preparations. But maybe I need to respond to the issues that were raised by Mr. Jobe. For Kochirira, let me reaffirm that we are going back to the drawing board to look at that facility, and let me promise that come the next year's UHC commemoration day, I think you'll talk of a different story. Just to also indicate that the government, through the Ministry of Health, is also constructing a number of health posts in the rural areas, and is also in the process of upgrading some of the health facilities to become community hospitals. So we are doing something. I would also like to extend my appreciation to all our development partners who continue to support to make sure that the health sector is properly resourced. A special thank you to all of you that have come for this meeting. We expect that towards the end of the meeting, Mr. Jobe and your team, I think it was important to also have action areas after the deliberation. I've seen that there will also be a panel discussion. Can we isolate some of those issues and make sure that we follow in terms of actions, so that as we meet for these annual meetings, we should be taking stock of what we have done before and moving forward. With that, I would like to sincerely thank all of you for coming and for your attention. I'd say zikomo kwambiri, and wish you also Merry Christmas and a Happy New Year. Thank you very much.
Can we give him another round of applause, please? Yes, maybe in case some of you are wondering, Kochirira, where is this? Where is this? Kochirira is in Mchinji. Some of you who are very familiar with Mchinji, as we're going towards Kamwendo, I think you branch off to your right-hand side. There's a certain road you take, so that's where Kochirira is. So it's a facility. If it can be transformed, it can save a lot of people, and we thank so much our guest of honor for that commitment. We're so happy for that. At this point in time, we would like to take a perspective of a patient rights-based approach. So want to hear from a lived experience from a patient, because when we're talking about universal coverage day, we should not also forget that there are a lot of patients out there who have got chronic disease conditions that are not able to access safe services because of these out-of-pocket payments, which are making things to be very difficult. At this point in time, in the interest of time, I will extend the microphone to Mr. Samuel Kumanje, who is representing. Yeah, I think you should be okay. Yeah, so he's going to introduce himself, and then he's going to tell us what has brought us. Over to you, sir.
Thank you very much. As he has said, I'm Samuel Kumwanje, a person living with kidney failure. I would like to request you, first of all, to take this presentation lightly. I understand you have got the presentation from WHO, from the Minister of Health, even from the Parliament as well. So I just wanted you to take this lightly in any local commercial break. You have had stuff, so relax a bit. But what I'm trying to present to you is the lived experience. I'll be talking of 21 years. That's the experience I'm going to share with you. Just because when we're talking of universal health coverage, there are critical issues that you need to know and incorporate in the system. It was in 2004, that is when I was diagnosed. I don't know when I started feeling the symptoms. I don't know when it started, the kidney failure started, I don't know. But when I was diagnosed, it was 2004. Ndegutena ali school, right? Sure. So I've lived up to date. Thank God I'm here to share with you. I usually also thank the medical personnel that have actually contributed to my living. When I was starting feeling the symptoms and the signs of the kidney failure, of which I did even not know, my family didn't know, even my wife didn't know as well, that there is kidney failure. So I went into different hospitals, and you could agree with me to say, in Malawi we have a tendency to shine from the government hospitals. Timakonda bit of private hospitals. So I went around the hospitals to only to find out that I was only being diagnosed with malaria, not knowing that the actual cause is behind the scene. And you could agree with me to say, ukapita kuchipatala kawiri katatu osapeza matenda aja, in Malawi we have plan B. So my relatives invited me to go back to the village to do the other way around, and the way we do it. But that did not help as well, until when my sister in marriage nthawi zina ukamakwatira kumaona. But my understanding was to go for a hospital whereby I would get my relative. That was now at Queens. When I went to Queens, I managed to get my sister there, explained, showed her the results. She could not believe the results because they were very high. She said, let us try to do another test as well. So I went and do the second test at the College of Medicine. I remember I met Dr. Nyirenda there, who actually did not believe the results itself. So when I went there, after that I was also told, after that I was told to say, you need dialysis. I said, because I'm already at the government hospital at Queens, I will do the dialysis. Only to be told that in 2004, the only dialysis unit which was available was at KCH. So I had to go back to KCH. I was at Queens, so I had to go back to KCH, whereby now I started my life on dialysis. I'm happy to say that during that particular time, I managed to meet a clinical officer. I'm sure today is at Chisu, Ozito Sauka, a very good doctor. I hope you know him. He's a very good doctor. And I want to assure you, ladies and gentlemen, don't underrate the medical personnel who are working in the government facilities. They are there to support. Maybe they have only limited resources, but they are there to work. He is one of them who actually contributed, and there are a number of doctors that have actually contributed as well. I wish if the Secretary for Health was here, he could have mentioned. He has been my doctor as well, who has been supporting me throughout the journey. Now, throughout my period, I've said about 21 years, there are a number of issues that I've actually lived in, participated, appreciated, and actually requested. As I've said that I did not know, my family did not know, even some doctors did not know that it should be a kidney failure. I feel there is the lack of awareness amongst our communities, amongst the general public, amongst the medical personnel as well. The second thing that I have actually appreciated is that there is late diagnosis within our health system, whereby you find that you go several times to the hospital not to be discovered about the problem. The doctors, they try to give you the best medication while they are treating a long disease. And the other thing that I've actually noted is that within this period, you will find that there is lack of infrastructures. As I said, in 2004, there was only one dialysis unit in Malawi. Thanks today, we are talking of Queens, we are talking of Mwaiwatu, we are talking of partners in Hope. I was yet to ask the Secretary for Health here to say, how far are we with the Nzuzu? Nzuzu, we need to have that one. I think it's in the pipeline, that they are developing another one. But you could see that when you're talking of the dialysis unit, they are only in Lilongwe and Luntha. What about our friends from Chitipa? What about our friends from Mangochi? I come from Mangochi. I was supposed to be in Mangochi enjoying with my family, but I relocated to Lilongwe to make sure that I have the access to dialysis. Now you find out that within this period of my life, I've also noted that there is limited resources. When I talk of resources, I'm looking at the medication. There is that persistent shortages of drugs. You talk of hydralazine, you talk of nifedipine, just to mention a few. You go to the pharmacy and they have got a very good language. They just write OS, and you sometimes don't understand. That is out of stock. At the same time, we are looking at the human resource. When you're talking of, more especially talk of the NCDs, we have got very limited people who have the specialized in this particular field. And the equipment itself, when we're talking of the NCDs, we are running short of the equipment. I had a time when I went to Kabudura Health Center, I would my BB machine ali now koma mabati alibe. So how are they going to do the test? They have the glucometers, but they don't have the glucose sticks. Even the HSAs, we appreciate the government has done a very good initiative to make sure that they are able to provide to the BP machine to almost every HCA in the communities. They have them, but the challenge is the same. They don't have the batteries. So we have done one part, but the equipment has to be fully utilized to make sure that people are able to access. We under the NCD Alliance, we promote that people should be going for screening, because we believe that when you're talking of caring, treatment is very expensive, but prevention is very cheap. So let's try to prevent, let's try to control, and I'm happy to announce here the World Kidney Day 2026 is talking of protecting the population, at the same time protecting the world. And somebody may ask you, say, well, what is the connection between the world and the population? You find that when you go to the dialysis unit, 80 or to 90% of the consumables are plastic, which means you're now destroying now the planet. So the best way is to control, to prevent the kidney failure. You need to control, to prevent hypertension. Not forgetting HIV. We recommend HIV, our partners. They have done better. I was listening to the radio the other time. They have reduced to 7%, which is much better. But now the 10 is on the NCDs. So the government is here, WHA is here, the parliament is here. I don't think I need to worry again. They are here to solve the issues. They are here to address our concern. UHC has just connected us to the right authorities. In the interest of time, let me stop there. Thank you very much.
Thank you so much. That was Mr. Samuel Kumanje, representing the Kidney Foundation and also the National Alliance of Patient Organizations in Malawi. Ndiye mwachidule kutengera simwene ndanza athu amene akutisatira mama ono pa Luntha angofotokozaso kuno kuti iwowa anapeza ndithu ndi vuto la impsyo kuti ndizo momwemo kuti kidney ndi impsyo. Yes, yeah, mu chaka cha 2004 ndikale ndithu komano kutengera ndi mmene dziko lathu ndi mavuto amene likuma nawo zikumakhala ndithu zinthu zovuta kwa anthu ona kuti sangakwanise, komanso kunena kuti maboma ena Malawi muno ngati kumangochi, komanso maboma ena mulibe ndithu pa Chingerezi chamatchula kuti kidney dialysis machine imene ndithu zimakhala ndithu ndalama zambiri, komanso ndi zinthu zokuti zimavuta kwambiri fota anthu ambiri amatogulisa katundu wawo ndi zina zotero ifo matenda amene wawa amafuna ndithu ndalama ndithu zokwanira. Nthawi ina yake bwana Kumanje anafotokozapo kuna kuti dialysis kuti chitike imafunika 200,000 session imodzi. I think ndi momwemo 300,000 akutiso yakwera ndi session imodzi kuti munthu upange kidney dialysis pamafunika ndalama kwana 300,000. ndiye kuti si chinthu chamasewa ndi patali kuti munthu ukafika pamene popo ndi mavuto ndithu. Ndeno mafuna tingomba ndithu mkota pamenepo. Ndiye pakali pano tifuna tsopano tilowe ngawo lachiwiri. Mungathe kuona ndi program yathu imene ilili kuti tifuna tikhale ndi zokambirana pa Chingerezi panel discussion, kuti tikambirane kuti kodi mavuto amene wawa tingathale nawo motani. Cholinga chake lero nchoona kuti tifuna ndithu kupeza ma solutions. We want to find solutions. That's why we are here this morning. Our colleague Nelly from World Health Organization and others. Today we want to have an event which is solutions based, together to bang heads to say, as we are wrapping up this year 2025, how should we move forward? So at this point in time, we want to tweak around our panel a little bit, I would kindly request Nelly, you can rest, you can take your seat, and then Peter, please come in front and take the place of Dr. Nelly Yatich to join the panel. And also, in front we have got Honorable Anthony Masamba. Because of the crucial role Parliament plays, I would recommend that he still remains in his seat. Would have said that maybe he should go, and maybe because of the crucial role, there are some questions which are very critical which we cannot skip Parliament. It's an opportunity that we have got Parliament this morning. So I would request that Honorable Anthony Masamba, please remain in your seat because there are critical issues maybe we would want you to respond. Peter, quickly come in front, join the panel. Our colleagues from the media who are here, please take note, this is our panel. Maybe we may not have sufficient time to do interviews, so if there are critical issues, please make sure of the panel discussion to capture photographs and also maybe critical issues. Maybe at the end of the program, we'll find a way that maybe you can also have some media interviews to those whom you want to speak to. As Dr. Nelly Yatich is leaving, now looks like our panel is ready to roll. I'm also informed that people who are fond of taking seats at the back, can you come in front to fill some seats, because I'm still seeing some empty seats. Maybe in the middle, there's still some gaps. Please, let's come and fill the seats here so that we are not, all of us who are not being behind. We are not at the back seats. So let's get started. So at this point in time, this is how we're going to move forward. Firstly, and first of all, want to hear from the Principal Secretary in the Ministry of Health, responsible for administration, Mr. Beston Chisamire. We talked about issues of social protection, protecting the poor from the catastrophic costs of healthcare services. We just want to hear from you in 2-3 minutes as we are reflecting on this particular important day, to say over the years Malawi has been exploring to say to come up with a national health insurance scheme. And I remember in 2012 government commissioned the Oxford Policy Management Limited to do a feasibility study to explore the setting up of a national health insurance scheme. Can you maybe tell us as where we are today, and where does the government maybe stand in terms of designing a scheme? Are there any discussions within the ministry, maybe with partners, to move forward? And then from Mr. Besson Chisamile, then we'll go to the Universal Health Coverage Coalition.
Thank you very much. Let me thank you very much, the Master of Ceremonies, and for the question. Just to start by giving a brief background, that the government, through the Ministry of Health and Sanitation, recognizes that indeed there are untapped revenue opportunities, including the establishment of the National Health Insurance Scheme that can support sustainable health financing in Malawi. You have indicated that there are issues of social protection. The majority of the people are poor, that they cannot afford to pay for medical services. So what the government is doing, there are a number of initiatives. Let me start with the civil service. Already the government has initiated the process that the civil servants are on a medical scheme. There are still discussions to extend, and I'm also aware that in most of the companies, in particular the private sector, the staff is also put on these medical schemes. As we move forward, government is also working on a number of policies that will ensure that we get resources. Already, as a step forward, the Ministry of Health and Sanitation has actually a dedicated division to do with health financing. And in that division, we are looking at opportunities that we can explore. And these issues are also highlighted in our Health Sector Strategic Plan 3. And what we are doing already before we started this panel discussion, I was talking to Honorable Masamba that we need to work together to ensure that we provide several avenues of health financing. I mentioned that in the mid-year budget review, government made a statement that the issues to do with insurance have been factored in, especially on accidents. But what we are saying is we need to move to other avenues. Already under the fuel levy, there are a number of levies, so we could also tap into those levies and the other products that the government can get some resources. I think for the time being, let me stop there. Thank you.
Thank you so much. Our guest of honor from the Ministry of Health, Mr. Beston Kisamire, for that intervention. So at this juncture, I wanted to hear from the chairperson for the Universal Health Coverage Coalition in 2 to 3 minutes to reflect, to say, as we are commemorating this particular very, very important day of the Universal Health Coverage, from your own perspective, what would you identify as some of the structural and economic barriers that continue to limit the progress of this country towards the achievement of universal health coverage? Just give us maybe a broader picture as we're also thinking about this problem we have in our hands in terms of the increasing out-of-pocket expenditure. Over to you.
Thank you very much, moderator, for the question. I think almost all the speeches gave information on that, and I will just repeat, but to be fair in the repetition, let me speak in Chichewa, because we all spoke about it. Chichewa, especially for those who are following, amena kuti wanelera kuti ngakhale muzokambira nzete kambirana pano tonse tikugwirizana kuti ndrama zopita kuzawo moyo zilipo, ntchito yabwino kuchitika. Mr. Kumwanje afotokozapo kuti tisamadelere ntchito yabwino imene amagwira ntchito, amagwira madokotala muzipatala mwathu, anene mwana athandizidwira, koma mavuto kuzawo moyo anakalipo. Mavuto amene alipo amaonekera munjira zosiyana-siyana, komano kugwirizana kwina tagwirizana ndikoti ndalama ndizochepa zopita kuzawo moyo, zofunika zitaonjezeredwapo. Mwachitsanzo kuonekera kwa mavuto kumaonekera motani. Pamene munthu wapita ku chipatala amuuza zimene makamba mu Chingerezi muja, amuuza kuti mankhwala awa palibe ukagule, kapena mankhwala awa tili nawo, ndiye kuti zimenezo zikulowa mu thumba la munthu ndalama, kuti ngati ali ndi ndalama akagule, ngati alibe ndalama sakagula. Komanso tikakamba nkhani ya imene timayitchula equity mu Chingerezi, imene inafunika kuti ngati mankhwala ali operewera, tikuyenera maganizira kumadera kumene kokagulako sikungapezeke, kuti apite kumene koko, chifukwa muli Longwe, mu Blantyre, mu Mzuzu, kupita kuchipatala kuzereka kagule mankhwalawo, pharmacy ilipo, upita drugstore ngati uli ndalama. Vuto limene lingakhale muloti ulibe ndalama, koma kuti mwina tipite madera ena kumidzi kwambiri kumene kwako ndimene kwene ukapezeka mankhwala kuti tikudziwa kuti ogulitsa mankhwala sapezekapo. Mwina masomphenya ena kumbalinga limene yangafunike ndioti anzathu apa MRA tikudziwa kuti mwina alimo muno tinawayitana Pharmacy and Medicines Regulatory Authority akuyenera kumalangiza anthu amapanga za malonda otsegula malo ogulitsira mankhwala ma drugstore ma pharmacies kuti azikatsegulanso mashopu awo kumidzi kuti umene kudzipezeka ogula mankhwala. Nkhani ndi ya kusowa kwa mankhwala ena. Nthawi zina anthu amalephera kupita kuchipatala chifukwa chakuchepa kwa anthu ogwira ntchito za chipatala. Tikudziwa kuti akhala kulembedwapo ntchito koma madera ena amamanga kumidzi munthu amatha kupita mmawa tsiku lonse ali kuchipatala chifukwa choti wogwira ntchito ndi wachepa akuyesetsa kugwira ntchito koma zimakhala zovuta. Nkhani ina ndi masomphenya a unduna wa zaumoyo amene akutifotokozera mu National Health Policy kuti munthu asayende 5 km asanapeze chipatala pafupi. Mwina ndifake unduna wanena kuti ukumanga zipatala cholinga kuti masomphenya adzakwaniritsidwe ndiye pali madera ena akuyendabe mitunda italiitali. Nkhani imene yakambidwa mu Chingerezi muja koma ndimafuna kuonjezera potengera zimene akamba bambo kumwanje. Vuto limene tili nalo ku Malawi lofuna kudziwa mthupi mwako kuti uli bwanji koma usakudwala kungopita kuti ukadziwe. Atifotokozera kuti nthawi imene amakafotokozera kuti ndi vuto la impsyo panali poti mwina atengapo nthawi ndipo ena analangiza kuti akayezetse ma U and E ndiye amanena kuti mwina anthu sitikudziwa amene tili munomo komanso anthu amene akutitsatira kungonyamuka kupita kuchipatala kukayezetsa BP sangapite, kungopita kuchipatala kukayezetsa shuga sapita. Zotsatira zake anthu amadzadziwika akudwala. Ripoti lina lake limasonyeza kuti mwa anthu 100 aliwonse ndi 13 okha 13 amene amapita kuchipatala kuti ndingodziwa mthupi mwangamu ndili bwanji. Ndiye tinenera kukonza vuto limeneli. Tikakonza vuto limeneli litithandizirapo kuti tichepetsenso kuchiza matenda kumene kumatengera ndalama zambiri. Koma nkhani yayikulu ndi yomweja kuti tipeze ndalama, tiyukitse ndalama zopita ku zaumoyo. Koma pamenenso ndalama zimene timanena kuti ndizosakwanira zopita ku zaumoyo, vuto lina limakhalapo anthu ena amapezera akuba mankhwala aja, akuba zipangizo za kuchipatala zija, zinthu zoti zikanakwaniranso anthu ena komano zimapezera zapitirira kucheperapo. Mavuto amene timatha kukumana nawo ndi amenewo. Ndimafuna ndingonenapo muchichewa chifukwa mu Chingerezi osamana lankhulana kamba kwambiri zikomo kwambiri.
Zikomo kwambiri. Amene ndi Mr. George Jobe wapampando chairperson Universal Health Coverage Coalition. Mchichewa tisanabwere kwa Honorable olemekezeka Anthony Masamba chifukwa issue ndi ofunika ndithu kwambiri. Nimangofuna kuti mwina in just a minute Samuel Kumanje nimafuna mungu tifotokozerapo kuti kodi ndi nkhani ya makidney mja munafotokozerapo yamba tingatona kuti amene wawa ndi also matenda achemna kuti angona eti ma chronic diseases. Inuyo mukuona bwanji kuona ndi dziko lathu mene likuyendera pakali pano kuti mafuta ambiri amene tikuma nawo tingatani makamaka kuti ma non-communicable diseases ma NCDs amene wawa tingatani nawo bwanji munthawi imene Malawi kumana ndi mafuta osiyanasiyana kuchepa kwa thandizo la ndalama kuchoka ku maiko akunja komanso kuna kuti anthu ambiri sakukwanisa kupeza thandizo chifukwa cha kubola nthumba kutengeranso ndi umphawi umene tinawo dziko muno. Mukuona bwanji pamenepo?
Thank you very much. More especially when you look at the strategic plan of Ministry of Health, you could even get a relief. Chifukwa chonena kuti imanena kunena kuti they want to improve the health status. Ndekuti akamati health status akamba za ifeyo. Now if you just want to get the put strategic plan kuchita as a goal is mentioning about the health status, patient satisfaction, that is very good. Now we are looking at what needs to be done. The first thing is we need to strengthen the primary health care system, more especially in our communities. We need to increase the awareness. We need to make sure that people are able to understand. Chifuatika pita kumudzi kuja ambiri sadziwa. You could agree with me, ambiri sadziwa. Andino akakhala kuti matenda aja afikira mwamuti ambe kuganiza za kuchipatala akayizetse timamba kuloza nazala pamudzi kuti ayi koma auji naje koma auji ni vaje. Ndiye chimene chikufunikira choyambirira is to strengthen the primary health care system. Yona kuti even at the grassroots level people should actually be working. Kuma health center kuja tipange empower the our health team which is there. At the same time, we should enhance availability of essential drugs. Mankhwala jangati sakupezeka, adherence ya treatment kwa patient imakhala yovuta. Not only that, but we have integration. Pali policy mene ku Ministry of Health akuyendetsa ya integration. Manager iso tipange implement, make sure that we are able to integrate the services, we are able to integrate the platforms. Not only that, but adequate, competent human resource. Mujandina nena kuti muntu nepoyamba ni mapita kuchipatala, koma madokta amene makumana nawo samatha kuzindikira. So we need to improve on that. At the same time, we need also to make sure that infrastructures imene tili nayo ikhale yokwanira mzipatala mwathu. Zikoma kwambiri.
Zikoma kwambiri Samuel Kumwanje. Pakali pano we want to go to the honorable member of parliament, the chairperson for the parliamentary committee on health. All these issues which we have been talking about, but there's one issue of strengthening primary health care, the issue of sustainable health financing, and also issues to do with having a health insurance scheme, which is quite very critical for the country in terms of achievement of universal health coverage. I just want to find out, being a parliament which is quite very new, what would you tell the stakeholders in terms of maybe the commitment that maybe we have been singing this song about the health insurance scheme, issues of strengthening our primary health care system for quite a long time. Do you think as parliament this time around, really we can achieve equity to ensure that people are able to access these services by ensuring that they have got that strong financial risk protection?
All right, thank you very much. So if you got the parliament, we must got the parliamentary committee on health. Timeti fa tipange tifunano tipange engage my stakeholders, Ministry of Health, Ministry of Finance, because the maunduna amene akupanga for directly on issues that we are discussing here. So if you look at the budget variances that are there, ndalama zimene amapereka ku nduna ndi zimene zimapangidwa execute ndizosiyana. Komanso pamakhala late disbursements. Malomota apereke January end, zimapezeka zoti akupereka mwina March. Zimene zija zimapanganso affect service delivery. Maloma kuti agule mankhwala kapena ma equipment oyenerera. Chifukwa choti achedwa zimapezeka zoti zinthu zina zake sizinaende bwino. If we have increased engagement with Ministry of Health, Ministry of Finance, kuti tionesesa kuti budget yathu yopita ku Ministry of ku health sector ikupita kumene kwa nthawi yabwino, komanso ma disbursements akupangikanso nthawi yabwino. But pali ma commitment ena amene tinapanga ngati dziko. Mwachitsanzo takhala tikunena za budget declaration. A budget declaration kuti tikwanisa kupanga 15%. We have never done that. The closest that we have reached is around 10%, if I'm not wrong, 10%. Komano panopos tingapange, we cannot hold the ministry or government to account chifukwa chosapanga meet their budget declaration. That was just a commitment. So if you ngati committee tikhala pasi tosa ngati a committee tifuna no tipange push kuti there should be a ratification, because tikapanga ratify the Abuja declaration commitment, it means that will be legislated domestically, and if we achieve that, they would now have authority to hold government to account. But as it is now, sindo kulibia kuti aboma tengalo zezala kuti nchifukwa chani simukwanisa 15%, because it's just a commitment. So commitment can be met or not met. If you look at the national health insurance, for us tuona kuti ndi pathway yotitha kutithandiza to generate revenue towards health sector, but timaona ngati kuti zinthu izizi zipangidwe in phases. Osangozuka lero kuti okay tose tiwene kuti tipange zimene. No, let's look at the groups. Kodi ndi anthu atiwo amene angakwanise kumasonkha, because we have the ultra poor amene sizingatheke kuti asonkhe. Excuse me. Pamene tili ndi anthu ena, the other group of people amene they are able kumasonkha zinthu ngati zimenezo. So timaona ngati titayamba in phases, kuti mwina tiyamba ndi central hospital, katipanga Lilongwe, Kazomba, ngati mmene tinayambira muja, kenako be scaling down ku district, kenako nkumaona kuti okay, which other group amene munatenga ipange, because the poor shall always be poor, amene they need to be considered. So these things need to be taken care of. But as we are discussing here with the SH, pali maleves ena ofunika kwapanga consider, ananenapo za mafuta for example. We can also consider sugar. Amene anenaso a chairperson wa coalition titeka also level umene uja, because sugar is one of the products amene so akupanga contribute significantly to diabetes. So we are not saying kuti anthu asamaje sugar. No, anthu akwena kuja sugar, because sugar is important as well. Komabe we are trying to broaden the resource envelope. Kuti tikatengako ku fuel, tikatengako ku sugar, tikatengako ka kumowa kumene kuja tikhano ndi resource imene ingatithandizire kuti health sector finances ikhale bwino. But as a health committee, if we increase oversight, tuonesese kuti procurement and supply chain kumene kuja katangale sakuchitika, the falsified and substandard drugs are also being checked. So there should be collaboration between the donors and the government. Public-private partnership should also be strengthened, because where we are going, we need to wake up and start thinking about how we can make sure that everyone is able to access affordable and improved quality health care services. So as a committee, we are here. This is your parliament. You are here to save you and to save people. Komanso kuti onesesa kuti wina aliyese kulandira thandizo la kuchipatala moyenerera. Ezomwe kwambiri.
Yeah, I've seen some people clapping. Please, can you give the round of applause? Yeah, our panel has done a very great job bringing us the critical issues. And what I like about this discussion are the solutions which are coming. I'm sure that our rapporteurs are documenting, and even some of us are taking notes. So from what he says, he's talking about if we want to come up with a very strong national health insurance scheme, maybe can we start exploring it in phases? Maybe we start with Kamusent Hospital, maybe Queens, maybe in phases to see how this thing can work. And also to look at the prepayment approach to say, because we realize that some people who are very poor, who can't even manage to contribute, who can we start with? These people who are in formal employment, can we start with the people? How can that work? So I'm seeing that these are some of the solutions which are coming out to say, if we want to have a scheme, let's explore to start with which group to start contributing. Very critical. He's also talking about legislation to say that since 2009, Malawi came close to 12 point something percent. That was more like the highest. But since then, the allocations to the health budget have been going down from 10, then it goes something like 9, and then 8, it goes up just within that particular range. So the issue of legislation is quite very critical, that maybe Malawi needs to have a law for accountability to ensure that we achieve universal health coverage. At this point in time, I want the World Health Organization, who have got Mr. Peter Chalusa, who happens to be the national program officer for the World Health Organization, who is responsible for health systems. So, Mr. Chalusa, from the United Nations, what is your take? We want to hear from you to say that as a country, we're seeing that aid is declining. Foreign aid, development aid is declining. Now we're hearing about the new arrangement which is just coming in. The US government is now reframing the whole concept of development aid to go to government to government. We've seen a lot of issues which are happening, which are also shifting the financing landscape for the health sector. As the WHO, what do you think should be done to ensure that we strengthen our health systems to achieve universal health coverage in the time where we're seeing a very significant decline in overseas development aid? Over to you, sir.
Thank you. I think I wanted to speak in Chichewa because often WHO we speak in complicated languages. So, but my colleagues may also want to hear what I'm saying, so I'll be combining. But just to maybe go back to the basics. Kodi tikamanena kuti health financing tukamba chani? Because sometimes we confuse, and I don't want to contrast or go against what my colleagues have said, but when we talk about health financing, kwambiri timakamba chani? I think there are three main things that are involved in health financing, and that's the first question that we answer is how do we raise money for health? That includes the sources. So that's what I think my colleagues have been discussing, and there are positives and negatives to whatever they have said, which I don't want to go into. But the second question is how do we pull those funds that we have gotten from those sources? And the last part of health financing looks at how do we purchase health services? So when we are discussing these issues, I think we need to be grounded on these issues of the three questions or the three objectives of health financing. Because sometimes we confuse employee benefits with health financing. So maybe just to go back to the issue of the national health insurance and the issues of tikale mwina ndi insurance kayatiyambe ndi those informal employments, is that health financing or is that a benefit to employees? So if you go back to the three fundamentals of health financing that I've mentioned here, some of the things that we promote as health financing, they may not be health financing. They may be employee benefits. The point that I'm bringing this is that we don't want to confuse health financing for UHC and the benefits that employees will get. Because if you start, like now we have got a public sector insurance, which others are arguing that should be progressed into a national health insurance. Kodi imene ijai ikhala health financing mechanism kapena imene ija ndi ma benefits ama employees okuti ineyo ngati ndalembedwa ntchito akundidula ndalama, employer akuwonjezerapo, then ndikadwala ndifuna ndipite ku mwayi wathu kapena ku Adventist. Does that help the poor person in the village? No, that doesn't help a poor person. In fact, the discussions that we have had with colleagues in the health financing division is that combining these two may have the potential of even taking resources from the poor to the rich, because the current mechanism that we have, which is grounded on taxes, the general revenue, is working very well. I think the issue may be, if we go back to the 3 points I raised, how do we raise money for health? If you take the employee benefits and say that you can convert that into financing for UHC, it will not work. It will not work, because then you put everything into one basket, and you know how we do things. Those who are in employment, those of us who are advantaged, we have gone to school, will end up pulling resources from the poor, and the poor will be disadvantaged. Because now, when we are funding, for example, district health systems, sitimayangana nkhope kuti ukukukaya tukathandiza auje because iwo anasonkha memo. We don't do that. We simply fund the structure or the system. So that way, things are working well. So there are several things that possibly I wanted to contribute as financing mechanisms that WHO promote, not only like in Malawi, but globally. So some of the things I think colleagues have already mentioned, things like health taxes, with smart earmarking on, for example, tobacco, alcohol, sugary substances. So, because if you tax this and you ring fence these resources to go to health, then you are bringing more resources to health, other than the other mechanisms that maybe we have been thinking about. So the underlying words here in terms of these additional taxes or levies is to make sure that they are ring-fenced. Ndrama zoziteteze zitetezedwe, ngati tikunena kuti tionjezera 200 kwacha tirekeze pafoja kapena chilichonse cha sugar, because we know sugar is contributing to a lot of health challenges. Mchere ngati tikunena kuti tikuyika ndrama zimenezozo ngati leve, tionetsetse kuti ndrama imeneyo isapiteso kugwira ntchito zina, ipite ku health. That means that percentage yomwe timayidandaula mwina kuti we can hit and 13% of the Abuja target, we could be able to achieve that, not within taking already from people who are already contributing, which would also ultimately harm the poor. The other area, an innovative idea that WHO promotes, are issues to do with broadening the VAT base. I think, and that also includes the improved tax administration. So there is an Addis Ababa convention that WHO convened, and this one highlights domestic resource mobilization as the core of sustaining UHC. We have known, and I think colleagues have mentioned, the challenges with the US government issues that we have faced recently. But we must put domestic resources at the core of funding UHC. Otherwise, tikadalira zobwera zija ndizi zomwe tumakhala ndi mavuto pakakhala kuti aine yake ndalama aja mwina anena kuti ifeyo panopo nafe tili ndi mavuto athu sitikuthandizani. The other area is the use of the issue of others have come up with the airline ticket levy mwachitsanzo. And this specifically goes to what? To health. These are new resources you are introducing. The other could also be debt for health or debt relief for climate health swaps. Now, for colleagues in UHC advocacy, this is an area that we can also engage donors to say, can we give us a debt relief? Because Malawi currently is spending a lot of money servicing debt. If those people can help us to give us some relief, so even wipe out our debt, on the understanding that those resources will go to health, that will bring new and additional resources to broaden our health funding. Lastly, of course, I still have a few things. I wanted to also say reducing fragmentation in health. At least in Malawi, we have got the one health, one budget, one M&D. That's another way of ensuring that we reduce inefficiencies. That way, the resources go to the needy or those who need those resources. So that's another way of increasing. Possibly, lastly, I can also talk about the other reforms that we are implementing, which we commend the ministry, expanding service level agreements, direct facility financing, but also maybe I can talk about pooled procurements and regional collaboration. These are some of the smart initiatives that we can do, because if we are procuring as Malawi small quantities, it costs a lot. But if we pool our procurements at regional level, it helps us. We get more for less. So I wanted to add that, and in conclusion or in summary, just to say that yes, our health funding or our health resources in this country are very little. And I think if you take out the external support that we get, we are in trouble if we may get complete stop, especially for funding for HIV services, maternal and child health. We have for many years relied on external support. So possibly, as we think through, let's start thinking in terms of how can we use locally generated resources as the core, as the pillar of funding our UHC goals. Let me stop there. Thank you.
Wow. What more can I say? It's been very clear, very elaborate, and he has talked about the importance of us to have a distinction, to understand universal health coverage and also health financing. He's talking about the need for us to expand some alternative financing mechanisms, for example, introducing earmark taxes, the excise taxes on sugary sweetened beverages. Yeah, we call them SSBs. Yeah, drinks like Froze and many others which have got a very high sugar content, and then in the end they are giving us a lot of health problems. And also maybe introducing airline levies, alcohol, and also introducing new taxes on tobacco. So these are quite very, very critical reforms, very critical areas in terms of strengthening our health financing for the achievement of universal health coverage. At this point in time, I'm seeing that time is running out. I wanted to do justice to our audience to now open the floor for the plenary. But don't worry, our panelists, I will get back to you as well to give another reflection. But we'll go to the audience now, and then we'll come back to the panel for your reflections. Because if I give you another round, then maybe we'll take out a lot of time. But we also want to give a room for our audience to give their comments, reflections, and then we'll get back to the panel to reflect. I'll now recognize 3 hands. We'll take a set of 3. Yes, I recognize you, sir, at the back. And also Sarah here. I want another one, a third one. I've seen 2, yes, and then at the back, then we'll start with you, sir. Our colleagues, I don't know if the mic can reach that far. Yes. You can just come in front.
I'm Hester Mkwenda Nyasulu, Country Director for AMREF.
Mwaswera Grace.
Ndaswera kai maive.
Mwagula mabuku kodi?
Ayi ndabwereka ku library.
Kodi yako ni secondary school so mmata kugwiritsa ntchito library ya school?
Ndichina chilichonse tu. Library, labu ya science, ya ICT, komanso maphunziro amakono apa phone, tablet, computer ndi digital learning. Timagwiritsa ntchito notesmaster.com. Ndi chimodzimodzi lophunzira aliyense wa ku secondary school ya boma.
Izi zinthu ndiye zosangalatsa. Maphunziro apamwamba ndithu. aiveru paja sanasankhidwe ndini madankhapa kuti kodi kadi ndipanga bwanji.
Etu ife tonse amene tinakhonza mayeso a 8 koma sitinasankhidwe kupita ku sekondari munasiyira sukulu ya sekondari panjira kapena mukufuna kutsitsa mapoints, dziwani kuti unduna wa maphunziro a primary ndi sekondari unakhazikitsa maphunziro a open secondary schools ngati njira imodzi yowonjezera mwayi wa maphunziro apamwamba kudzera msukulu za sekondari za m'madera athu kumene kuli aphunzitsi odziwa ntchito yawo bwino komanso zipangizo zapamwamba zoyenera pa maphunziro. Musazengereze, kalembetsani lero ku open secondary school ya mdera lanu kuti mupeze maphunziro apamwamba.
Uthengawu akukupatsirani ndi aunduna wa maphunziro aku primary ndi secondary kudzera ku Equals Project ndi thandizo la ndalama lochokera ku World Bank.
And due to the stop orders or maybe the financial challenges, they are struggling to expand. So I would like to know what sort of plans are in place by the government to help these organizations to expand. Because maybe they are lacking maybe transport like ambulances, the drugs and the like. Thank you.
Good morning. I'm Davis Mwachumu. I work for AIDS Healthcare Foundation. My question goes to the PS administration. Ndifusa nchichewa. Ifeyo ngadaye chefu ma facilities medu gira munchito muli kada ina yake imene timayiremba ntchito imene timayitchula kuti psychosocial counselors amene amathandiza kuti munthu akapezeka ndi matenda a HIV athe kumpanga counsel to avoid my issues of mental health. Now what is happening is that ma facilities ambiri anthu amene wawa mulibemo nde boma limadalira social welfare office. Now anthu social welfare makapezeka pa district, which means in our health centers there are no such cadres to support anthu amene apezeka ndi HIV and HIV. Kodi funso ndiloti kodi ndikotheka kuti boma lipange consider kuti to recruit a cadre ya kakhale ma social welfare officers omwewo koma akati ukapezeka mma facilities or kupanga any other mechanism, be it a training for existing cadres so that anthu amene akupezeka ndi HIV and AIDS azitha kulandira upangiri in terms of to prepare them in terms of mental health when they are found HIV and AIDS positive. Thank you.
Thank you so much. I hope our panelists have been noting those questions. Who wants to start? I will not just put everyone on spotlight, but who is comfortable to start? Okay, Honorable. Sir.
Ziko mwambiri. I think mafunso amene anabwera ku nduna wa za umoyo loyamba ndi kuti mabungwe amene si aboma amene akuzidwa ndi kuvuta kwa ndalama kapena kuyimitsidwa kwa ndalama zimene maiko ena amatipatsa kodi tingawathandize bwanji. Choyamba ndikuti mmene timagwirira ntchito pali mabungwe amene monga pa council paja amachita nawo participate. Choyambirira tiyambire ngati pa council paja titapita pa council paja pali anzathu amene amayang'ana za maplani ndi ena otero atakhala nawo pansi akhonza kuona kuti kodi bungwe lilo panopa kuvutika bwanji kapena angathandizidwe bwanji chifukwa mmene decentralization ikuyendera panopa maka makanso ndikuti panopa boma likuyika ndalama zambiri makanso kutanthauza kuti maplani ambiri amene angachitike pa council po ndi mabungwe amene si aboma akhonza kugwira limodzi malinga ndi ma priorities amene alipo. Komanso ifeyo ngati kunduna mabungwe eso ena amene timagwira nawo ntchito directly tita kukhala nawo pansi nkuona kuti kodi chuma chimene chikubwera padakali pano ndi ma priorities aboma kodi kumene tingathe kwambiri kuyika chuma chathu ndikuti chifukwa choti pano tikudziwa kuti ndalamazo zikuvuta komabe titakhala pansi nkuona kuti kodi chimene chikufunika apapo kuti tipange ndi zotani ndalamazo zikhonza kukagwira ntchito moyenereramo mwinamo nkuchepetsamo. Panalinso funso la anzathu amene amakhala ma counselors kuthandiza anzathu amene angawaunikire ku matenda a HIV AIDS. Ndizoonadi kuti ma counselor ndi wochepa. Ndathokoza kwambiri kuti munaperekanso njira imene boma lingatsatirepo. Ndatengapo phunziro kapena maganizo choyamba amene akugwira ntchito ngati makhansala m'madera mwathu kodi tingawapase ma training program otani kuti atha kufikiranso anthu ambiri. Anthu omwe aja amene alipo pa ground tikhonzanso kuwapanga training kuwaonjezera makaudaulo ena izo nzotheka. Komanso mbali ina kuboma kuti malemba ma health surveillance assistant amene ajawonso pa programu yawo imene amakaphunzira mwina titayikapo component ya kuti kulimbikitsa nkhani ngati za pachichewa counselor kuphunzirapo so njira zoti angakhale bwanji alangizi mu matenda osiyanasiyana mwina si HIV AIDS yokha komanso muzina zambiri. Ndikhulupirira kuti tonse titayikapo nzeru zathu pamodzi tikhonza kupita patsogolo. Zikomo kwambiri.
Zikomo kwambiri. I think the same question was directed to us as a committee. I think first of all I should begin by saying that effective advocacy is that which uses evidence. Kapena tiyankhule chewa kuti advocacy ende bwino pamene kuti pakhale kuti evidence ndi umboni. Yes, umboni pakhale umboni. So parliament because a committee is parliament, so parliament imagwisa kwambiri ntchito umboni. Nde ifeyo ngati komiti choyambirira timenera kuti tikhale ndi umboni tiupeza bwanji pamene tafufuza tapanga investigate. So ma issues ngati amene wawa ifeyo ngati committee ndekuti we take it upon ourselves tifufuze tipange gather evidence chochitisa ndi chani kuti mavuto ngati awa akhalepo. Tikakhala ndi evidence imene yoyo ndekuti tipanga provide solutions or taitana ku Ministry of Health kapena responsible ministry kandi local government ka finance kuti pali ma issues awa amene akuchitika, can you do something about it? So ifeyo kwambiri kwake tiuza evidence kuti tipange push agenda komanso ndekuti oversight yathu ija kuti itheke ndekuti tikuyenera kuti pakhale evidence yomwe ija komanso pakhale collaboration ndi anthu amene tikugwirana ntchito aja. So without evidence ndekuti ntchito yathu singayende bwino. That's why we rely much on evidence kuti even oversight ija izikhala kuti tupanga zinthu zolondola, because we cannot subpoena a stakeholder or anyone involved in malpractice kuti timpange subpoena abwere ku committee without evidence ndekuti paibe chimene tingapange. So we need to have evidence first of all kuti even advocacy yathu ija iyende bwino. So tigwirana ntchito with evidence available, we'll do everything possible to make sure that these issues are flagged out and to make sure that there's availability of drugs across districts. Thank you very much.
Thank you very much. I think if Solimozi limene linabwera mbali ya kuno more especially inachita stress ponena kuti I've been on dialysis for 21 years. Any form of intervention, a number of them have been done. But before I go into the details, let me just explain a bit. Kunena kuti when you have been prescribed for dialysis umayenera kukhala for 12 hours a week, which means katatu per week. Komano ndi kuchepekedwa kwa resources kwathu kumalawi kuno timakhalapo 8 hours kawiri per week. If you go on Monday, you go again on Thursday. If you go on Tuesday, you go again on Friday. At the same time, Wednesday and also Saturday. So in my scenario, they would in my nasobita kawiri for dialysis. Ndibita under normal circumstances, ndimabita Tuesday masana, ndi Friday masana. Kungoti, I didn't want to mention that. Kunena kuti as I'm talking, Nderuka Central Hospital dialysis unit has been closed. Kon mano sinafune kuinena because it's with a good will to maintain and improve the service. For close to 2 or 3 weeks, it has been closed, but the engineers are there. So I was supposed to be on dialysis this afternoon. Command for I have been closed. The government, with the initiative of Minister of Health, Yadipanga split into private hospitals. My colleagues are in Luntha, are doing at Maiwatu. Some of us are doing at partners at the expense of the government. We are not paying, the government is paying. So I'll be going for my dialysis tomorrow. I think by 7 o'clock to 12 o'clock, about 4 hours. Now, Menedin Kayamba, I did not actually know kunena kuti kodi moyo ukhala wotani until when I was told by the nurses that menezi kuonekera panopa ndiye kuti mukhala pa dialysis moyo wanu wonse, which had it been that pa forum ya doctors tikanena they should take note of that, kunena kuti anzathu HIV akamauza za matenda amatenga bwino pamene ife ama NCDs mankhala ngamba takupeza ni DBP takupeza ndi chakuti without considering reaction imene munthu ja aitenge. So it was a very painful, because by then nali kuti ndangopeza so ntchito ku Masafu kuti ndizikagwira ku Baraka. Now I've been told kuna kuti usibwera ku dialysis ku KCH. You can imagine traveling from Baraka to Lilongwe twice a week. It wasn't very easy. So by then I had a person amene anakhalapo for dialysis. I think ena mwakumbukira Vice President Amalewes amene nachitika nawo mwayi ndikukumana nawo ndikundilongosolera kuti there is an opportunity for transplant, that you go for transplant. I don't think I need to go. I think you understand it cannot transplant. So, but the problem was, by that time for me to go for transplant, it required me 11 million malai kwacha. Then the salary yatu ya nthawi imene yoyo sizimagwirizana one. But the access ordinary ndi opportunity yokumana nda Vice President, there was an opportunity. Chifukwa amene timapangapo dialysis nthawi imene tinalipo anthu awiri okha. So it wasn't much to support 2 people. But the challenge was the aftermath of transplant. Chifukwa when the government has sent somebody kaya ku India, kaya kuti amasonyeza kuti vuto jakuthana nalo, but that's different with kidney failure. Akakupanga transplant, because the transplanted kidney is a foreign organ into your body, you need to have a certain medication imene izitsisa immune system yako, so that the body should not recognize that there is a foreign body. That drug by then malai kunesima pesika. I'm sure asungati panopo yamba pesika mwapo ndi apo at a very high expensive. Panopo as I'm talking, I have some colleagues who have done that. They are spending 2 million a month to buy that particular drug from the hospital. Manapangayo. So you could see that for me it was very difficult, more especially on the resources. The other thing was anything happening to me after transplant, I was also supposed to go back to India, kayandi China, kayandi kuti that they should do maybe the X-ray or whatever. Kapena even the new kidney has failed. Kutaga ichotse panai kunoko, as I'm talking kulibe so amenanga ichotse, then I need to go back to India. So you could see that nitachita ways into his will. Let me just maintain this one which is still available. Of course by then I didn't give out 50-50 let it happen. Komano, those were the challenges for me to say ndipite transplant ndiza kumanabe ndi mavuto ena ndiena. So that's that. We have done a number of intervention, making sure that we work with the ministry to make sure that they'll be sending people. They should be able to analyze those people that are capable to go for transplant. But still the question is, kodi tikatumiza anthu ku transplant amata za achita monitor ndani akabwera ku transplant kuche, because you need to check kuti kodi kidney yako ikugwira ntchito bwanji. So you find that the first year that the person has transplanted amapeza wapita ku India kuja not less than 4 times, which is also giving the cost. I think in the interest of time, let me stop there.
Thank you so much, our panelists, for responding. I'll come back to Dr. Chalusa from WHO and Mr. George Jobe from University Health Coverage Coalition shortly. But quickly, I just got an intervention here from our colleague from Manit. We wanted to respond on something very critical, the issue of this particular cadre, which is missing. He has got an idea. So, come, please.
Timangofuna kuti tiyankhepo pang'ono funso limene anafunsa Mwachumu from AHF pa nkhani ya ma counselors. Ndikananena kuti ine ndi Mr. Manyamba kunapam tiyankhe koma ndiyankha malo mwa Manyamba. Malawi muno anthu amene ali pa ma ART it's about 900,000 plus. They would anthu positive, they are on ART, and on sale they need psychosocial counseling. Ndi kada imene mukunenayo ndiyofunika kwambiri. Komano since the onset of HIV we have a cadre yama support groups. Many zilindi any person who is on ART, the government has a record. Ama mudziwa aliyense by name, by location, mudzumena makala. So we have a support system from the health center, from the hospitals, akapita kumudzi kuja. Ndi pamene neno pamakhala ntchito kuti pakufunika a support system. So NAPAM has support groups. And then we also have a lot of support groups amene aphunzitsidwa bwino on how they can counsel people living with HIV amene ali ndi mavuto osiyanasiyana. Yes, there is need kuti anthuwa aphunzitsidwe bwino, akhale ndi ma skills. That cadre imene mwayifotokoza ija ndiyofunikanso kwambiri. So there is need for us, I think, to work together. IHF, Permanent Plus, NAPAM, Coalition of Women Living with HIV, Komaso Achinyamata, Tidindi AY Plus, and so on. Mavuto andi ambiri. Mukuona even in the universities, pakumavika nkhani zoti ayi wakuti wazipa chifukwa amuza kuti ali ndi HIV. Zimene kwa anthu ena ndi zinthu zakalekale kwambiri. Because now HIV is manageable. People can live 27 years, 30 years. Tidindi anthu okuti they are living with HIV, they haven't killed themselves, and yet somebody is killing themselves. So nimangofuna nene kuti tigwire ntchito limodzi. IHF timatiti kalemba proposal nangasema ipitisa sokunja kuja. Mamoti ine ndikukamba ndi Mwachumu mukuyipitisa kwina. Ndi amaona ngati kuti mwina ntchito palibe yokuti tigwire. Tigwire limodzi kuti tithandizane so that we can achieve universal health coverage. Thank you very much, moderator.
Thank you. Sikoma kwambiri. Mafuna soti bwereso ku panel yathu kai pang'ono ina 2 minutes nofuna tibwere kwa Dr. Peter Chalusa mwamva ndithu zomwe anthu afusa ndithu komanso nkhani ya makada undi ofunikira kwambiri ngati ino amene mayang'anira nkhani za health systems kupanga support kuti ntchito ziziyenda bwino nkhani ya human resources for health kuti kugwira ntchito mchipatala komanso nkhani ya psychosocial support komanso mwina tisangoona mwina HIV yokha komanso tionenso ma chronic disease conditions amene kaya ni cancer ndi zina zotere zimafunika nazonso counseling of some nature ngati WHO nkhani ya health systems strengthening mukuona kuti mwina ntchito imene tingapange mwina motani from there then inso mwina tibweranso kwa George Job.
Of course, nkhani imene sinaiganizire kuti ibwera komano yes, I think we know kuti the cadre of psychosocial services or support service providers omwe now they are community health workers. And I think they do a good job, not only counseling or encouraging people to remain on treatment, komanso they provide upangiri munjira zambiri. Mwina munthu akamaona zina zake, they consult those people within the communities. Possibly, the right mwina anzathu amene angakambe bwino in terms of thinking about this, kuti kodi kupita kutsogolo, how do we, because I think the alendo athu olemekezeka anakambapo za ma HSA amene nthawi zambiri timagwiritsa ntchito mu community, because I think this is the cadre yomwe imakhala kuti ili papero ya boma. We know HSA ntchito zake zimakhala zambiri. Job description yake imakhala ngati ili open ended, pakabwera ichi timponyere HSA pabwere ichi. So I think I remember a few years ago there was a discussion kuti bwanji titakhala ndi a specific cadre yoti izipanga handle nkhani ngati zimene zizi, not kuti timunjikireso HSA. I know it's easier to kumponyera HSA, koma in the end timatha kuaphunzitsa muona kuti fodali ndi zinaso zambiri zopanga, they don't dedicate their time on this area because amapanga zakatemera, water and sanitation, you know. So maybe kuunduna, this is something that they can think about. We need to introduce this cadre. I know there are those providers, those trained to a degree level, koma sitima apesa mmidzi amene acha, and it's difficult kuti mungakamnene kuti mumulemba akakhale kumudzi or mwina pa even pa health center, it's difficult. But I think it's an issue of having the position mapped within the Ministry of Health kuti tikhale ndi cadre imeneyo, koma I think mwina anzathu atha kutiunikira kuti is this something maybe they are already thinking about or planning to have. But yes, we agree we need these people, and it's long overdue in fact to have these people hired by government and delivering the service.
All right, so George, do you want to say something? Pali zambiri zimeweza kampito anakamba hapo ndito azat from AMREF kuyang'ana nkhani ama commitments kuti tizitha mwina kumayang'ana kuti chaka chikamata tizoona kuti tapanga kumwina chakuti kupanga ticket ya komanso kuona ndichunso nkhani imene tikambirana nkhani ya health system strengthening kuyang'ana makamaka anthu ogwira ntchito mchipatala amene ofunika kwambiri. Mwina kutengeranso ndi nkhani zathu zimene tikambirana lerolo universal health coverage, mukuona kuti mwina tingagwira ntchito mwina limodzi motani kuti mwina tipangenso tionetsetse kuti anthu azipeza ndithu thandizo la zawo moyo makamaka kuonetsa kuti anthu ogwira ntchito mzipatala zikhala kukwanira, chifukwa mankhwala atakhala kukwanira koma ngati palibe support systems ngati ogwira ntchito amene awa ndikuti ntchito isokonekera. Maybe in just a minute before we go towards wrapping up.
Mwina ndingonena kuti zambiri zakambidwa kale kuchokera WHO komanso kuchokera kuunduna. Olemekezeka athu honorable Masamba anena kuti pamene pafunika evidence tipange package evidence. So HF pamene mayankhula ili ndi evidence yawo, managed plans ili ndi evidence yawo. We package that, then we continue with these discussions. Ministry yafotokozapo kuti mavenue osiyana-siyana kuphatikizapo ma HSA alangiza za umoyo. ndiye ndikana kuti mwina muchichewa pali mwambi amati nkhwangwa sithwera pachipala kuti machita kunolanso ndiyoti ndi nkhani yofunika kupitiriza kunola watenga maumboni yanchani rather than ku workshop umwe kupangidwa nkhwangwa kuti ikhale kuthwa ikamba kugwira ntchito nthawi imweni ole chiwanje tikagula sithwa chili mu shop ndiye tipitiriza kunola ziko
aitentaombere manjeti ayi zinthu apo ndetu ya tino kuti zayenda bwino so at this point in time ndimafuna mwina tibwereso kupanel yathu kuti aliyese mwina kupanga ndithu pa Chingerezi mati parting shot kuti mwina kuomba nkota koma mwina ndisanatero mwina kuthawa mwina wina alipo mmodzi mwina kuopa kotcha blanket amatala achewa umazati ineyo mwina andikhomereni nofuna kulankhula koma analepera alipo mwina mmodzi koma I'll just give you 30 seconds for nthawi yatithera tikufuna kuti timalize palibete chabwino alipo okay just in 30 seconds please.
Thank you so much. Funso langa lufuna lipite kwa PS malingana ndi mene tamvera kuchokera kwa akumwanje nkhani za mavuto amene akumana nawo anthu makamaka amene akudwala ma NCTs, in his case kidney failure. Zikuoneka ngati kuti makina awawa dialysis mdziko munomo amene anenera ndi ochepa komanso ochepa omwewo akumaonongeka. I think last week or this week tinamva zokuti ku KCH vuto limene lachitikanso okuti mukumatumiza odwala mzipatala za private. Kana boma limamva bwanji kuona kuti pali ma patients madera osiyanasiyana kutali kandi kuchitipa kukaronga amene amayenda misewu yovuta. In his case Mr. Kumwanjana nazoti anasamuka kumangojo dzakhala kunoko alipo ambiriso amene anasamuka madera kwawo kuti adzandikane ndi thandizo limene lili koma ena amene sangakwanise zimene zizamachokerabe kutaliko kumabwera kuno kufika kuno peza zoti makina avuta ku Luntha kumakhalanso vuto limene nthawi ina amatumizaso kumabwera kunoko. Going forward vuto limene lili ngati boma mulikonza motani kuti anthu amene akuvutika ndi kidney failure asamavutike ngati kuti si anthuso si amalawi ngati wina aliyense. Zikomo.
Zikomo kwambiri. Alice, come in front. Introduce yourself. I'm giving you 30 seconds, please.
All right. Thank you so much. My name is Alice Chiweza, working with the Association of Malawian Midwives. Nimafuna and Ndifuse, I think of course I wanted to touch on the same issue which he mentioned on the healthy workforce. We understand, of course mostly I will be speaking, there are my midwives coming from the Midwives Association. Posa bjedo abano, UNFPA, anatulusa State of Midwifery report, mchidwedi madisome report, ya 2024. Imene mafotokoza kuti chiwerengero chama midwives ku Malawi kuno chikutsika chachoka from 7.2 chafika 5.5 and mulipoti mwanafotokoza kuti ngati palibe chimene boma lichitepo pa nkhani imeneyo ipezeka kuti dziko la Malawi ino likhala ndi shortage ya ma midwives okwana 8,000. So I wanted to know, considering that I think from the media budget review, Minister Kupanga present one of those 3 measures, anafotokoza kuti boma silufuna lilembeso anthu ntchito ambiri. So I wanted to understand on how the government, be it the parliamentary committee, even the Minister of Health, through the Principal Secretary of Administration, kuti kodi pa nkhani imeneyo mutithandizira motani, considering kuti as a country we are already doing well, kuchepesa imfa zazimayi oyembekezera. But tikaona kuti chikakhala chiwerengero chikupitirabe kutsika, it means kuti tikhala tikubwereraso ku mavuto omwe ajakale chiwerengero chikhala chikupita chikukulira. So ndimafuna ndizoti kuti in the midst of those austerity measures kuti tikhala tikupanga motani kuti tithandizire pa nkhani ya chiwerengero cha ma midwives ku Malawi. Zikomo.
Zikomo kwambiri. Ndithu mafunso ndithu ndameneyo ndeno kuona ndi nthawi yathu kuti atithera chomwe tipange pakali pano tifunsa ma panelist athu kuti 30 seconds nthawi yatha mwa changu then kumapeto tipempha olemekezeka athu based on chisamire poseka panali ndithu mafunso ena ake amene akupita kuboma mungoti ankhako ndithu mwachidule mawu anu okhala ngati oseka koma pakali pano tingopanga 30 seconds aliyese kuti tikhale ngati tikwangule then kenako chisamire angoti pasako mawu omaliza komanso mkungu yankhako pang'ono then tikhale tutamaliza.
Mwina tikaona bandandanda wanthu olankhula kumapeto amene sakulankhulira kumwanje mutongo apatsa mpata iwo kuti enafe kutseka kwathu konse kutokalano tili m'maspeech kale amene tikulankhula ziko
akumwanje mwayi ndi umenewo koma you have 30 seconds please.
Zikomo kwambiri. First of all, I would like to appreciate that you were here, and a takeaway home for you is that nothing for us without us. If you want to do activities, engage us, meaningfully involve us. Thank you very much.
And nakuti nothing for us without ya chijowa chake kuti bati chijowa chimavuta chabwino pakali pano tsopano tipite ndithu kumapeto kuti timalize ndiye mafunako a chair athu a Universal Health Coverage Coalition tibwera kale poti ndikali chapafupi nawo mwina in just 30 seconds mawu anomaliza tiseke then kenako timalizira olemekezeka athu guest of honor.
Zikomo kwambiri potengera maulemu amene aperekedwa kale ma protocol. We want to thank you very much, our guest of honor, the PS for administration, the Minister of Health and Sanitation, and the Honorable Chairperson of Parliamentary Committee on Health, WHO, Mr. Kumwanje. On behalf of the UHC coalition, I would want to express our appreciation that you all came. And I would also want to express appreciation to the team that has organized it. We had officials from the Ministry of Health. We also had the WHO participating. Mr. Okero was there, and the rest of the colleagues. Let me also, from what has come out here, commend government, Ministry of Health, that when the dialysis machines are being serviced, government is taking the patients to private hospitals and meeting the bills. I think that's the way to go. And some of you don't want to clap hands for government. That is the very welcome, and you cannot be silent on that. In which case, even when the demand increases, probably that's the way we can also go to use the private sector. Let me, on the behalf of the leadership, now appreciate those who have financed this function to happen. We are here under financial support from partners in health, and also AHF, Last Mile Health, and Action Aid. Without their support, we could not have managed to meet here. Probably it could have been an online function. So we thank you very much, and we also know that others have, have funded the activities in the past. Let me also acknowledge those who participated, who supported through staff time, attending meetings and organizing, running up and down. Thank you very much. And thank you very much, moderator, for the good work that you are doing. Thank you, Luntha, for streaming to ensure kuti anthu ena kwena konse akutsatira zimene zochitika pano ngakhale Lilongwe Hotel zomwe kwambiri nonse amene munatsatira invitation yathu tinatumiza mwabwera on a Friday Zikomo kwambiri, zikomo.
Nkhani yabwino kwambiri. Pakali pano tibwera kwa Dr. Chalusa kuchoka ku WHO. Tikachoka kumenepo tipita kwa Honorable Anthony Masamba kenako timaliza ndolemekezekatu. Pakali pano Bwana Chalusa, please.
I don't have much to say. I will just stand here. So, on behalf of my colleagues from WHO, I would like to thank the guest of honor, Secretary for Health Administration, for leading us in these discussions today, but also Chair Mr. Jobe. I think last year we also held a similar. We also had a panel discussion, I remember, and you did also a very good job in bringing us together and ensuring that the function went well. So we also want to commend you and ask that you continue with this great work that you are doing with all the other UHC coalition members. I don't have much to say. I want just to end by reading some statements from the WHO platform about the 2025 UHC Day campaign theme. I think just to remember that more than half of the world's population still lacks access to essential health services. And we know when they say more than half of the world's population, they are just being generous. The truth is that majority of people in sub-Saharan Africa, particularly countries like Malawi, countries including Malawi, lack essential health services. And a quarter of these people face serious hardship, financial hardship, when it comes to paying for health care out of their own pockets. Often at the expense of food, education, and housing. If you have ever had a member of your family who is having a very bad medical condition, and you have been told that you cannot get help at the government facility, and you have to go to a private facility, and you don't have money. The only resources you have, maybe you had planned to buy 2 bags of maize for that month. Maybe you wanted to pay school fees for your child. Now you have one of the kids sick, and you have to pay for health care. It's a serious situation, right? It's very serious. Sadly, majority of our fellow countrymen, every day they are going through this situation where they have to balance. It's not like paying for health care itself, but even transport to go to the nearest health facility. They have to balance. Should I buy maize for my 3 children, or should I pay for Kabaza 5,000 to visit a health center which is 15 kilometers away? These are real challenges that we are facing every day. So for me, I want to end by calling on our civil society colleagues. I think it's high time that we bring back the energy. You know, after the ART program was scaled up nationally and things have been going well the past maybe 10-15 years, CSOs we have kind of slowed down. But I think what has happened recently is a call to action. We need to wake up. We need to wake up. Otherwise, if we don't wake up, I spoke about debt relief for health. These are things that we need to be pushing. We need to make sure that all those energies we used to have, all those midnight meetings we need to have, let's reinitiate them. Otherwise, one day we wake up, we find that even money for ARVs, they have disappeared. What are the 900, you say 900,000 people that we have? What are we going to do? Are we going to pay, do we know the cost of 1 month supply of ART? Some of us, we don't know. It's a lot of money. So my ending remark is really to call the CSOs in this country to wake up. Let's start lobbying the advocacy. Let's start it again so that financing for health is prioritized. Not only through those mechanisms we have spoken about, there are many other ways, including engaging the embassies in this country, the international organizations. Let's bring back the Lusaka agenda at the table and make sure that funding for health is at the top of the agenda wherever we are discussing things. Let me end there and thank you, honorable guest of honor and colleagues, for inviting WHO to this discussion. Thank you.
At this point in time, Honorable Masamba, please.
All right. Thank you very much. Guest of honor, Secretary for Health Administration, WHO representative, Chair, USCA Coalition, and all members present here. Inandimafua ndinene kuti Malawi ndiziko lokuti litha kupanga zinthu modabwitsa, because if you look at the MDG4 mwachitsanzo, Malawi inali dziko loyambirira kupanga achieve MDG4 kunoko kwa Africa amidst all the financial constraints that we were going through, but we managed to do that. If you look at 3.95, Malawi had already achieved that way before time. Looking at the data in TB, we are hovering around 47% and 68% reduction in deaths there. It means Malawi ndioti irinkutegera kuti titha kupanga zinthu patoka. What we need is to make the right decisions. Kodi ma decision yake ndotani pamene tukambirana zinthu moona mtima, because if we choose to have freebies all the time, then we'll be here for a very long time discussing the same issues that we are discussing now, because imene kufuna ifeyo ndicho kuti chilichonse chaulere. And when we do that, it means the money that was supposed to be invested somewhere, that money will be given to us. Palisazo zambirimbiri zimetengapereke. The issues of primary health care, I've always argued in some platforms that if we want to achieve the quality health care services in Malawi, where we need to begin is to invest in primary health care, because everything begins right there. Health surveillance assistants are a few, HRH, Human Resource for Health, nurses, midwives here, the doctors, clinicians are few. We just gotten the evidence here, 5.5 reduction. What we need to do now is to make the right decisions. As Parliamentary Committee on Health, like I said, we are here to collaborate with all the civil society organizations, the NGOs. Engage us. We are there to provide oversight. We are there to offer solutions where necessary. What we need is evidence. We investigate the issues where we need to investigate. We will subpoena officers where we need them to be summoned before us. At the end of the day, what we need to ensure is that there is that affordability, accessibility of improved health care services, because in so doing, Malawi will be better. But at the core of everything, because the discussion that we are discussing here is all centered on health financing, what should we do? That is the question that we need to be answering when we are going outside this forum. We need to come up with mechanisms, health financing mechanisms, the other options, the engagement, and other options that will help us finance the health system here. With these few remarks, ladies and gentlemen, we are happy to engage with you, and this is your parliament. You can reach out to us every time that you have the issues. We'll be there to work with you, and we'll be there to partner with you. Thank you very much. Enjoy your holidays.
Thank you very much. I think before I do the closing remarks, allow me to respond to the issues that were raised first. Ndingo yankhaponso mchichewa kuti nkhani ya matenda ngati ma NCDs, nkhani ya kutsekedwa kwa dialysis facility ku Kamuzu Central Hospital, ndizoonadi kuti boma linatseka facility ya dialysis ya ku Kamuzu Central Hospital. Boma litaona kuti nkhani za ukhondo kumene koko sizinali bwino, poopa kuti anthu azipatsirananso matenda ena ndi ena boma linaganiza zotseka ndiye bomalo nthawi imene limatseka anayika ndondomeko zoti mapeshenti ena adzipita ku zipatala ngati Partners in Hope ndi facility ina ku area 43 kandi 47. cholinga chake ndikuti mmene boma likukonza mashiniwo anthu akhalebe akuthandizika. Pano ndi chite report kuti kampani imene inatipatsa mashini amene aku Kamuzu Central Hospital wiki yomwe ino ayamba kukonza, tikuyembekeza makonza mashiniwo, tikuyembekeza kuti nthawi ina iliyonse mashiniwo ayamba kugwira ntchito. Maplani athu ndi oti muzipatala zina zikuluzikulu ngati Mzuzu Central Hospital, zina za maboma ngati mene kulili ngati kumpoto kuti Karonga Chitipa, pali maplani oti zipatala zinazo kuti anthu asamayende mtunda wautali tikekonso ma dialysis machine. Kumabe plani ya boma ndikuti kodi after dialysis tingamapange chani. Pali zinthu zina ngati ma transplant amene tikuaganizira kuti tikonzanso kumapanga kuti mwina tisangoyika ndalama zonse kapena upangiri wonse ku dialysis machine. Komanso ndinene kuti kudzera mu partnership tikukambirana ndi anthu akufuna kwabwino amene akhonza kubweresanso machine a dialysis pa public private partnership. Izi zithandizanso kuti zonse zosadalira kwambiri boma komanso ena atengepo mbali. Panali nkhani ya midwife pa chichewa ndecha azamba tamva dandaulo loti manambala azamba kuchepera. Ife akunduna wa zaumoyo ndi mapartners athu tikutsimikizireni kuti nthawi imene tikuganiza zolemba anthu ena ntchito tiganizira makadi amenewa tili ndi mafacility ambiri, ena ndi aboma komanso ena ndi achamu. Tika ndondomeko yoti nambala iyo isachite kutsikiratu. Ndiye tikutsimikizireni kuti kudzera kuboma ndi mapartners athu tithandiza pavuto limeneli. Ndi mawu amenewa mundilole kuti potsekera msonkhano uno ndithokoze kwambiri anzathu a Universal Health Coverage Coalition chifukwa chotibweretsa pamodzi. Mwaona pali anthu osiyanasiyana amene atengapo gawo. Chimene tingatenge kuti tikamapita ku nyumba ndikuti ndizoonadi kuti ntchito za umoyo zili ndi mavuto ambiri, kuyambira nkhani za mankhwala, nkhani za anthu ogwira ntchito, komanso kumene amatithandiza ndalama anzathu akunja. Pakati pa zikuoneka kuti akuchepetsa ndalama zimene angatipase ngati dziko kuti tithandizire ntchito ya za umoyo. Ndi kutsimikizireni kuti kunduna wathu wa za umoyo tayambapo kale maplani okonzekera kuti kodi tikadzafika tsiku lina kuti anzathu asakutithandiza tingatani. Chifukwa chake nkhani ya health financing ikubwera, ndi kunduna wa za umoyo tili ndi division imene ikuyang'anira za health financing. Panopa pakuchitika zinthu zambirimbiri, komanso ndigwirizane ndi olemekezeka athu, olemekezeka aonabo Masamba kuti atilonjeza kuti tigwira ntchito limodzi mu ndondomeko zimene tikufuna kuti ngati dziko tizipeza ndalama tokha kuchokera mu mataksi osiyanasiyana. Komanso tifuna tilumikizane nawo kuti tipange legislation kuti tikamapempha ndalama samakhale kuti kodi mphamvu zake mwazitengera pati, koma tionesesa kuti mu chaka cha mmawachi zimene ziteke tikhala tikulumikizana nawo anzathu aku parliament komanso ama civil society kuti kodi tingayike ndondomeko zotani kuti tipite chitsogolo kuti dzikoli tithandize anzathu amene ndi osauka. A WHO ananena kuti ambiri over 50% ndi oti sangakwanitse kupeza ndalama zoti azithandizire ngati atadwala. Ndiye ife mudziko muno tikufuna tipeze njira mogwirizana tonse ngati mene tasonganirana pano ndi mfundo zimene tapanga kuti tikamakumana ma meeting ena amtsogolo kandi chaka chammawa tidzakhale ndi njira zonena kuti kuchokera meeting imene tinakumana ku Lilongwe Hotel pa 12 December tapangapo izi zimene zitithandiza kuti tipite patsogolo. Ndi mawu amenewa ndikuthokozeni anzanga nonse amene tili limodzi ku high table, Mr. Jobe, aku WHO, Mr. Mr. Kumwanje, takuthokozani kwambiri. Ndikhulupirira kuti testimony yanu imene mwaperekayi anthu atayiwunika bwinobwino zikuoneka kuti nzotheka bola munthu utakhala open and kuvomereza kuti anthu akhoza kuthandiza. Honorable Masamba ndife tonse amene tabwera kuno zikomo kwambiri zikomo.
Zikomo kwambiri apapa ndi tina kuti ndi pamapeto zochitika zathu lero zokumbukira Universal Health Coverage Day. Remember kuti zochitika zathu lero zinali ndithu live, zili live pa Luntha TV live streaming ndithu imene. Komanso undizo kuti pali ma refreshments ena chitakale ndithu koma enafe ndiye kuti tione kuti tithandizana bwanji kumene kumboyoko. Komanso just want to make sure kuti aliyense akhale kuti asaina ndithu zina lawo, ma email komanso ma phone number chifukwa tufuna kuti tonse tiziyenda ndithu limodzi. Ndi everyone should make sure that they should sign. Ndi pakali pano mwina ndikupempha kumuna munthu mmodzi atisekere kuti pemphero. After that ngati pangakhale mwina ma announcements in terms of ma logistics, mwina kapena akubwera kama logistics then kena kuti second pemphero. Anyone? Komanso penaso tipemphaso anzathu apa panel ngati pakuli kotheka. Okay. Ndiye azathu for the media ngati mufuna kuma interview kumapeto, I think you are free to do that kuti taseka chiri chose. So komanso wangu ndimanga remind kuti tikaseka zonse ngati kuli kotheka chifukwa event yathuyi sinapange chithunzi cha group. Group photo is very very important. Sikangomwazikana ndiye kuti tikaseka zonse tipita ndithu panjapo somewhere. Tili ndi photographer wathu ochoka ku PIH tikhale ndithu ndi chithunzi ndithu very colorful one, chithunzi chabwino. Ndiye tingopemphako amozi atisekere ndi pempha. Anyone? Please.
Thank you. Am I allowed to do logistics and then pray? I pray first? Okay. Let us pray. Heavenly Father, we thank you for a beautiful day that you gave us today, that we were able to discuss issues of national importance and those issues that can help our sisters and brothers in different communities. May you give us the zeal to implement what we have discussed so that we can see progress. As we go back, we ask for your protection until we meet again. In Jesus' name we pray. Amen. Thank you.
Logistics of camera. Okay.
Luntha Television stands as an autonomous faith-based broadcaster with a national and international reach. Experience the difference with Luntha Television, where innovation meets experience. Auto-educated team backed by cutting-edge technology ensures seamless execution and unparalleled results. Luntha